Good afternoon, my people. Let me just start by welcoming you back to my YouTube channel. And I do appreciate those who are commending my job and those who are appreciating what they are getting from this content. And this gives me more morale to continue giving you educational bangers each and every day. For those who have given their topics and they have not been discussed, I always say just be patient with me, because these videos are not so easy to make. It requires a lot of time, a lot of thinking, and I have so many topics which have been given out, but be assured that your topic must be discussed. However much time it takes, but I will have to give you what you requested. Thank you for the support that you are giving to this channel, because if it were not for you, maybe I could not be making these videos and the channel could not be where it is. We are still discussing about malaria, and our emphasis, or most of our focus, is on malaria in pregnancy, and we are still continuing with the World Health Organization guidance for prevention and treatment of malaria in pregnancy. And before we continue, if you are there and you have not subscribed, you are still watching this video, make sure you hit the subscription button, put the notification bell on, so that whenever I upload any video, YouTube will automatically notify you and will never miss any of our content. So, World Health Organization guidance for prevention and treatment of malaria in pregnancy. The reason as to why my main focus is on malaria in pregnancy is because most of you ladies and requested this topic about malaria in pregnancy, and it affects majority of our mothers while they are pregnant, and they end up losing their pregnancy prematurely. So, World Health Guidance for Prevention and Treatment of Malaria in Pregnancy. We started discussing the first one, which was intermittent preventive treatment, and we are still doing the last bit of this subtopic. So, the last dose of intermittent preventive treatment for malaria in pregnancy with SP can be administered up to the time of delivery without any safety concern. Let me repeat this. The last dose of IPT, or intermittent preventive treatment of malaria in pregnancy with SP, can be administered up to the last time of delivery without any safety concerns. That means from second trimester to third trimester up to delivery, it's safe to give SP without any safety concerns. That means during that period, it can't affect your pregnancy and it can't affect your body negatively. Intermittent preventive treatment for malaria in pregnancy should ideally be administered as directly observed therapy. That is what we call DOTS. IPT should be administered as directly observed therapy, or DOT. That's why we always give this medication or these drugs in our presence. We make sure that the lady swallows in our presence. That is what we call directly observed therapy. SP can be given either on an empty stomach or with the food. So it's safe to take it when your stomach is empty. Alternatively, you can take it after eating. Folic acid at a delayed dose equal or above 5 milligrams should not be given together with SP, as this counteracts its efficacy as an antimalarial. This is very important. Folic acid at a delayed dose or equal or above 5 milligrams should not be given together with SP, as this counteracts its efficacy as an antimalarial. So you should not give folic acid together with SP at the same time. You can give the SP, then tell the mother to start the folic acid 72 hours later. World Health Organization recommends daily iron and folic acid supplementation in pregnant women at the dose of 30 to 60 milligrams at elemental iron and 0.4 milligrams of folic acid to reduce the risk of low birth weight infants. World Health Organization recommends daily iron and folic acid supplementation in pregnant women at the dose of 30 to 60 milligrams of elemental iron and 0.4 milligrams of folic acid to reduce the risk of low birth weight infants. Maternal anemia and iron deficiency at term. Let me repeat this. World Health Organization recommends daily iron and folic acid supplementation in pregnant women at the dose of 30 to 60 milligrams of elemental iron and 0.4 milligrams of folic acid to reduce the risk of low birth weight infants and maternal anemia and iron deficiency at term. SP should be administered to women receiving cotrimoxazole prophylaxis. Prophylaxis always means that you are giving this drug to prevent, not necessarily to treat. The patient may not be having this kind of an illness, but you give just to protect. Let's discuss about the next prong, or the second one, which is insecticide treated nets, or ITNs. ITNs should be provided to women as early as in the pregnancy as possible. Should be given in earlier pregnancy possible. ITNs should be provided to women as early in the pregnancy as possible at the antenatal clinic or through other sources in the public or private sectors. ITNs should be provided to women as early in the pregnancy as possible at the ANC clinic or through other sources in the public or private sector. It's not a must that you get a net from the public institution. That means private sector also can supply the nets. The World Health Organization Global Malaria Program recommends distribution of ITNs, or insecticide treated mosquito nets, to achieve full coverage of population at risk of malaria. The World Health Global Malaria Program recommends distribution of ITNs. ITN means insecticide treated nets. So the World Health Organization Global Malaria Program recommends distribution of ITNs to achieve full coverage of population at risk of malaria. The best opportunity for rapidly scaling up malaria prevention is free or highly subsidized distribution through existing public health services, both routine and campaigns. The best opportunity for rapidly scaling up malaria prevention is free, highly subsidized distribution and through existing public health services, both routine and campaigns. So you can do campaigns whenever there is a malaria pandemic. You can supply the mosquito nets through the already public health services, all through campaigns, diagnosis, prompt parasitological confirmation by microscopy or by RDTs is recommended in all patients suspected of malaria before treatment. Prompt parasitological confirmation by microscopy or RDTs is recommended in all patients suspected of malaria before treatment is started. Treatment solely on basis of clinical suspicion should be only considered. Treatment solely on basis of clinical suspicion should only be considered when a parasitological diagnosis is not accessible. Treatment solely on basis of clinical suspicion should be considered when a parasitological diagnosis is not accessible. This marks the end of our discussion today. Thank you for being with me. Thank you for your support, and let's continue subscribing, liking and sharing our videos so that they may reach as many people as possible. Have a wonderful day ahead.